Good evening, good afternoon, and good morning to everyone from all over the world who are participating to our advanced training session on disease outbreak investigations and surveillance, infectious disease epidemiology in field and communities, which is organized under our Global Advanced Certification Program on Strategic Research Collaboration and Communication for Emerging Researchers in LMICs, and the International Workshop Series, proudly organized by the Global Consortium of Global Health Actors, Leaders, and Thinkers, Global ALT, and the Global Health Forum, the Global Health Brain and Mental Health Forum, in collaboration with local delivery partners like Bangladesh Institute of Innovative Health Research. Today marks the session 7 of our advanced training sessions. Which is already featured by eminent speakers from all from different institutions from different countries like USA, Singapore, Malaysia, and even from India. So we are uh, honored to bring today our esteemed speaker, Dr. Anoop Velayudhan, scientist, medical, Indian Council of Medical Research, New Delhi, India. Today, our session will be moderated and hosted by Professor Maheshwar Satpathy, the CEO of Global Alt and Director at COE ECCPH PHP India. Who, if we discuss about our organizers, Global Consortium of Global Health Actors, Leaders, and Thinkers, Global ALT, operates under the Global Health Leadership by Global South Initiative, a flagship project of the Global Health Forum. The consortium brings together global health experts, researchers, practitioners, and policymakers, especially from developing and underrepresented regions, to collaborate on transformative research that drives equity and systemic change in health. As of today, the Global Consortium is the largest dedicated professional consortium of global health with more than 2,000 leaders from 170 plus countries who have applied to be members through a rigorous process of member selection and full documentation of members' credentials. Our vision is reimagining Global South, sorry, 1 minute. Reimagining global health leadership by the Global South, decolonizing global health, we are the global alternative. The Global Health Forum, elevating voices, reimagining global health, building equitable futures for all since 2018. The Global Health Forum is a dynamic international platform committed to transforming global health through inclusive dialogue, critical research, and ethical collaboration. As the parent institution contributing to the Global Consortium of Global Health ALT, GHF serves as a bridge between academia, policy, practice, and communities, especially those from low and middle income countries and underrepresented regions. GHF envisions a future where global health is decolonized, democratic, and driven by the lived experiences of those at the margins. We create space for cross-disciplinary exchange and nurture the next generation of global health leaders through strategic training programs, public health forums, and capacity building initiatives that cut across the geographic borders, cultural and social milieu, and disciplinary boundaries. The Global Brain and Mental Health Forum, reimagining mental health leadership for a resilient and equitable world. Since 2020, GBMHF is a collaborative interdisciplinary platform dedicated to advancing brain health and mental well-being through research, policy, mental health well-being, through research, policy, advocacy, and international knowledge exchange, founded as part of the broader vision of the Global Health Forum and to complement the mission and objectives of the Global Alt. Bangladesh Institute of Innovative Health Research is a non-profit, student-led research organization that promotes research culture among students and early career researchers. So some ground rules for our session participants. Please remain muted during the session unless you are invited to speak. You can raise your hands and you can also express your questions or reflections in the Q&A, and we will take out your questions in the Q&A session. Use the chat box actively and the Q&A for your reflections, and attendance will be tracked from start to end. An attendance form will be shared during the session anytime, so please be attentive to so that you don't miss out the attendance form. Maintain a respectful and inclusive environment throughout. Chat box will be monitored regularly. Any unnecessary, repetitive, disrespectful, unprofessional, and hateful comment in the chat box or Q&A targeted towards anyone will be deleted and such persons will be removed. So let's move to our advanced training session on disease outbreak and investigations and surveillance, infectious disease, epidemiology in field and communities. Our esteemed speaker is Dr. Anoop Velayudhan, and the moderator is Professor Maheshwar Satpathy, who is a world-renowned leader in One Health, global health, planetary health, brain and mental health. He's a much sought after expert in epidemiology, health emergencies and implementation science, and health innovation using the power of emerging and futuristic technologies such as AI, ML, LLM, and generative AI, and geospatial information system science and technologies, and remote sensing. He builds on his core areas of expertise in cognitive and computational neuroscience, psychology, and global health to benefit humanity. His sustained engagement with UN Sustainable Development Goals and ethics in broader area of public policy has led to holistic societal transformations in various LMICs. Professor Satpathy has a humble H index of 79 and cumulative citations over 156,000 plus. He has published extensively 285 plus peer-reviewed scientific articles and book chapters in journals of global repute, notably in Nature, Science, The Lancet, NEJM, JAMA, etc., and has offered keynotes and invited talks at more than 200 top international conferences and global congresses in the past 20 years. He has an impressive all-metric score of 68,255, exemplifying the large-scale social impact driven by their work. So I would now request Professor Maheshwar Satpathy to introduce our esteemed speaker and start the session. Thank you.
Okay, thank you, Faisal, for the brilliant and generous introduction of the organizers of today's, as well as my introduction. So it is my utmost honor and pleasure to welcome Dr. Anoop Velayudhan to the stage of Global Consortium of Global Health. So Dr. Anoop Velayudhan is a scientist E Medical at the Indian Council of Medical Research ICMR in the Communicable Disease Division at the headquarters, New Delhi. He is the program officer for One Health and also works in surveillance, pandemic preparedness, and biosafety and biosecurity. His core expertise is in outbreak investigations of infectious diseases and has years of field experience in setting up surveillance systems in many states in India. He is a member of the Interministerial Action Council on One Health and at the National Joint Outbreak Response Team NJORT, and serves in expert panel of various committees of the Ministry of Health and Family Welfare, Government of India. Dr. Velayudhan earned his medical degree MBBS from Government Medical College, Kochi in Kerala. He received his Masters in Public Health MPH from the Sri Chitra Tirunal Institute for Medical Sciences and Technology, an institution of national importance and eminence. He is a Fogarty Fellow 2012-13 as a part of Asian Collaborative Network for Chronic Non-Communicable Diseases, Ascent Scholar. He trained at the Sao Paulo School of Advanced Sciences for Epidemic Preparedness, Brazil in 2023. He trained as an international project officer from CDC Atlanta and is formally trained by IMA International in monitoring and evaluation for developmental projects, and is a black belt in Six Sigma. Dr. Velayudhan was an assistant program officer cum epidemiologist in Kerala under the revised National Tuberculosis Control Program, and later an Epidemic Intelligence Service EIS officer at NCDC CDC program, and was posted at State Surveillance Office, Chennai. He worked for CDC India, country officer as public health specialist for 5 years, and led the AES surveillance program and contributed in the AMR and public health workforce team. He also formally mentored EIS officers at the NCDC, WHO EIS programs, and the Advanced Field Epidemiology Training programs. He also consulted for the WHO CRO in various roles and for WHO Nepal. So Dr. Anoop has a humble H index of 10 and cumulative citations over 500. And as a BG field professional, I think that is speaking about his academic scholarship. So with this very humble and brief introduction of Dr. Anoop Velayudhan, I would request Dr. Anoop to conduct the training program. Our training participants are very, very excited to have you, Dr. Anoop, and we are also equally to have you. We are very happy to have you. So therefore, we cannot wait anymore to listen to all your brilliant perspectives and experiences over the last 20 years. And obviously, I'm confident that we are going to enjoy your training. So the stage is all yours. Please feel free to use the stage. And if you want to conduct any polls, anything, all the options exist. And feel free to ask them questions also. They can respond in the chat. So Faisal, please keep the chat open throughout the period, and they can so that respond in the meantime. But please ask the questions only in the Q&A. We'll not pick the questions from the chat. Only ask questions in the Q&A section, so that we pick them and we respond to them. Okay. So, and participants, please be engaged, but don't post anything which is not relevant to the training program. Okay. Thank you. Dr. Anup, if you are ready. Thank you. Dr. Anup is dark all of a sudden. Correct. Go ahead. Okay. Participant, please stay tuned. Dr. Anup seems to be experiencing some internet issues or some issues. He will join back as soon as possible. Okay. Stay tuned, please. This is one of the interesting experiences of being born and raised in an LMIC, that the current may go out anytime. You are attending a meeting and current goes out. This happens to me on a daily basis. Okay, in different meetings also. So let's remain empathetic, um, and I'm sure Dr. Anoop will be joining us any moment. The chat box is not disabled. The chat box has been enabled now. All of you are able to use it, but use it with discretion. Do not post anything which is not respectful. Okay.
Yeah, sorry about that. It seems like we had to start with a bang. Yeah,
No problem.
so this is one very interesting example of how things can go wrong, especially in the settings that we are working in, especially in global south. So,
Yes, yes.
sort of exemplified that when we are trying to start a class or a program and the power suddenly goes off. So, what do we do? So, this is a perfect example of somehow God has exemplified it in the right sense. So, taking it on the right note, thank you, Professor Satpathy, for that very gracious introduction. So, the way I would like to introduce myself is I'm a humble student of public health, and I learn more from people and from events and from the field and the patients and the affected communities rather than I do from the textbooks. So I have had a deal of formal education from classrooms, but the most of my learnings have come from textbooks. So if you permit me, sir, I can share my screen and then go ahead. So I am able to share the PowerPoint now. So and I will share it. So again, it's a great opportunity to be here and to be part of this community and to teach all the stalwarts here. So there, unfortunately, we won't be teaching anybody because you're all experienced people in public health. So if you had expected a teaching session today, sorry to disappoint you early on. So I will be sharing my perspectives and examples that I have learned from the field with you, which will certainly be an insight into what is there in public health.
Dr. Anoop, can you
So
please
I
make
hope
it
you can
full
see
screen?
my
Yes,
screen.
please. Thank you.
Yeah. Yes. So thank you. The session today is titled "Disease Outbreak Investigations and Surveillance," uh, and welcome again. So I would start with an introduction on what I hope to discuss with you. Key topics that I thought I should actually formulate into and go into depth are: how do we strengthen surveillance systems? What are the recent developments in surveillance that we can all learn about? What are the advanced outbreak investigations? Because I am sure all of you must have got an inkling of some sort of outbreak investigation that you have been part of or you have actually seen as senior leaders in public health. Next, I wanted to touch upon the challenges and how to mitigate them in field epidemiology overall, so that is where the real information comes in. In India, we call them districts. In UK, we call them counties, and Australia, we call them counties. So I wanted to touch upon where does the real epidemiology flow in from. And I also wanted to discuss about future directions for surveillance and outbreaks. And as policy leaders, because I realize that most of you are middle level or high level leaders into this. So, what can policy leadership shape what goes on in the field and in surveillance and in outbreak? So, this is the thing. So, my objectives are to equip you with advanced skills for designing, leading, and supervising disease outbreaks. I hope to go beyond the basic surveillance principles that we all learn from our textbooks. I also want to explore the real world barriers and operational strategies for investigating outbreaks. Because we all live in challenging communities and field contexts, as we have just seen, we have power outrages, we have media looking upon us to make a scapegoat. We are mostly in rural, urban slums and tribal areas where even the logistics of how to reach there, which vehicle and who to coordinate with is itself a challenge. I would like to demonstrate some modern surveillance tools and framework, including the event-based surveillance system, some sort of syndromic surveillance, and how to integrate them in the digital arena with practical examples that I have from India and global context. So this also includes some form of AI tools, GS based that has been for a while. Maybe we can also discuss shortly on how to use the next generation technology for that. I would like to discuss the leadership roles in coordinating multi-sectoral outbreaks because the world has now become a world of One Health. And seriously, everybody, including WHO and other leading agencies, are recognizing the role of One Health and the One Health approach in pandemic preparedness, in disease outbreaks, and in real-time surveillance. We will try to see how to make rapid decisions under uncertainty, how to align stakeholders, and to manage the political and public expectations. So, added to this, there are certain critical elements that I believe must go hand in hand. So, these are the ethical, legal ramifications and the community engagement aspects, which most probably uh, you know, we tend to over we tend to not see them when we go to the field or plan from our headquarters. So I would like to touch upon actual dilemmas faced during COVID, Nipah, or even influenza outbreaks. And I want to basically leave you with high confidence in interpreting surveillance data, how to, design quick response strategies and oversee post-outbreak reviews, all sort of as skill building, where Dr. Satpathy has said that would actually make you a better public health professional in the field than we have been. So this session actually matters because all of us at the middle level and senior level manage routine surveillance very well. But then the pressure points emerge when there is a huge hue and cry, especially in global south where democracies are very vibrant. The public demand for a response is quite high, and you actually are designing rapid investigations that are time sensitive under high scrutiny and would need something sort of a multi-sectoral coordination between the departments. So an example of this is the 2018 outbreak that we had in Kerala, a southern state in India, where we required swift leadership decisions on quarantine, contact tracing, and hospital protocols because Nipah was a new disease and quite everybody was surprised that we somehow managed to diagnose Nipah, and then everybody was in a quandary. This being a high morbid disease, how would we deal with it? So people started really reading swiftly the protocols in Malaysia, other parts of country, and in Bangladesh, and then people just reached out to scientists who actually had some experience on it over phone. And I remember there were overnight calls between Bangladesh health systems and the Kerala health systems led by NCDC. So this failure would have amplified human to human spread, and luckily we had a limited number of deaths at that time, but then it was significant because it was a newly diagnosed disease. So this training is also for district surveillance officers, state epidemiologists, and program managers who know, some sort of uh, disease integrated disease surveillance basics, but you would need advanced field investigation tactics. So my focus is not only on data collection, but how to integrate them using rapid response teams and to coordinate lab networks along with it. So here is an important task for real-time risk communication, where all the sectors need to be aware of the risk and communicate it to the public in an integrated fashion. So I also want to connect it to One Health because the arena of One Health is very dynamic. Around 75% of emerging and re-emerging diseases are today coming in from zoonotics, and around 65% of all outbreaks are linked from some sort of zoonotic exposure. They say every 4 years, a new high potential pathogen is actually emerging. We have seen MERS, we have seen SARS, Nipah, and avian influenza, and we are all trained in the human health system. But it is critical that today we understand the animal and environmental health surveillance linkages. We also must know how people and teams work in the animal and environmental domain. And we need to learn to work with them, or we will not have anything to, work at all. So, at the outcome, I would like to make you confident enough to lead outbreak teams, handle media or rumor crises, and troubleshoot real barriers, or at least have the mentality to think about. And this is all that we are facing commonly as public health uh, experts field. So that whenever you go to a remote or risky context, you can be sure that you can actually think about what others have faced and have take similar approaches. So one key update or the emerging trends in outbreak investigations are earlier it used to be that somebody comes from a neighboring village or a family flies in from abroad, and a new case is detected. So it was simple. The field epidemiologist, or what we call in India, the rapid response team, or the public health inspector would know what has happened. And somebody new has come in, or a new shop has been set in, a new restaurant has come in, and then you have a foodborne outbreak. Today, it is not the trend. The drivers of outbreaks themselves are changing. We have climate change at an unprecedented level. You can see I'm still sweating in Delhi, even in room that is well cooled. And then you have a rise of urbanization in such an unprecedented level that somebody was telling me other day, 2-degree increase in global temperature is actually exponentially affecting all the other factors connected with human health. And then there is this human animal encroachment upon nature that has increased the frequency and complexity of clusters. Like today, you have urban dengue, rural Casanur forest disease that is peculiar for India. But then you also have cases like scrub typhus being reported from an urban area, a perfectly urban area like Kolkata. Some of us have known Kolkata. And then you have diseases which are of interest. Like in Brazil, there are so many Epstein viruses and lumpy skin disease that nobody had seen in the animal sector. And the second trend that I would like to touch upon is event based surveillance. So, this is something that people have started using complementary with the traditional systems that are actually using informal data sources like social media, news reports, or community rumors to catch unusual events. We have a system in the integrated disease surveillance system in India where you have a dedicated room for rumor surveillance and media scanning that actually four people do, with around 20 televisions tuned on to all the regional and Hindi channels that catch up any sort of news report that is comes in regarding health. And every day at 8 o'clock, there is a summary report of the news reports that are coming in through the news and media channels. And again, there is this WHO's epidemic intelligence from open sources, or that is a new paradigm that seeks to complement the usual channels of signals that can come from the field. So, this is a new concept that, if we get time, we will be touching upon. And then media monitoring. India has started early dengue outbreak signal monitoring from media, specifically in certain high burden dengue diseases. So trend three is that when the syndromic surveillance is something that we are closely going back into. Some of us who have worked in HIV and TB programs know that syndromic surveillance was something that HIV and sexually transmitted diseases program used widely. So again, to supplement traditional methods, we are going in for acute febrile illness surveillance, acute, uh, you know, uh, encephalitis syndrome surveillance. That is what ICMR is currently working upon. We have around 10 institutes linked to a national lab that AES syndromes. So that track actually Japanese encephalitis cases that are coming up in risk zones. So syndromic surveillance that actually look for a cluster of syndromes, like if you talk about AES, it looks for sudden seizures with or without any fever. It also looks for irritability and any loss of consciousness in a patient of any age. So the approach is syndrome based rather than going in for an one or two symptom based. The fourth trend that we all know about is like when COVID struck, there was a mass adoption of mobile apps, dashboards, and cloud data sharing. Most of us would have seen some sort of data dashboard that all the news, all the national media, irrespective of where we are in, irrespective of our countries, people show it, Power BI figures, and every day there used to be a sensational news, especially in India, that COVID cases are rising up in this part of the country or going down. Death cases have been reported from this counter country. So this is nothing but real-time digital reporting and information presentation through dashboards for policy making and swift decision. So the trend five that I wanted to touch upon is the latest thing, the latest buzzword I would say today. AI and predictive modeling are now practical. So, but the thing is, if you take around, everybody is jumping onto this bandwagon of AI. So, I've been looking at proposals that come into ICMR for funding. and at least I would say 65 to 70% of proposals, they just add in the word AI so that it sounds better. People don't know what to do with AI. People don't know how they will do it to AI, but they just put in AI saying that we will do some sort of chatbot or some sort of integration of data, and you do some logistic modeling and call it predictive modeling, and we will have that in our proposal. So this is not what AI is. We have some applications that have come up. uh, Currently we have applications that use it for flu forecasting in the US, COVID wave predictions using predictive models were a huge thing in India even when it was coming up. So, one thing that I always say about predictive modeling or disease models are that all models are wrong, some are useful, which says that most models don't actually tell you what will happen, but you can use it to somewhere to, have a response system prepared for what would be the number of beds you would require, what would be the critical care apparatuses you would require, and what would be some sort of healthcare numbers that you would need to keep prepared. Again, examples are the Google flu trends that are a global outreach, and IHIP upgrades in India are currently also doing work on vector-borne disease mapping, along with climate change data and also the vector data that is currently available. So, next section, I would like to touch upon and talk about surveillance strengthening. Some of the modern surveillance strategies that are currently in trend there. One is an integrated system of surveillance. Earlier, it used to have the health system used to have all these layers, the national, state, and district level data that used to send up data up, and then action would be following in a reverse manner. It used to be centralized action, and it used to take at least a minimum of 1 week. If you consider at least the case in India, it used to be 1 week. It used to be weekly reporting, and the hot cases used to be verified through RRT visits, and the lab networks used to be a separate entity which would receive the samples from the IDSP reporting and then send back the data. But today, there is an integrated surveillance. There is no single method that can actually report. The modern systems in the world today combine passive reporting system like routine IDSP data, active case finding. We have set up sentinel surveillance for specific high priority diseases at specific sites where you have repeated reporting. And there is also this event based triggers that are picked up through media or even something like a rumor registry. So the key principle here is to triangulate information, get as much information from as much sources as you can, and then verify it independent of each other, and also look at the connections between each other. So this is basically not a traditional health approach. It is basically an intelligence approach. So triangulation has always been an intelligence agency word, to triangulate information that federal agencies like FBI or central agencies in India like CBI is used to use. So this is what we are using in the health sector today. This helps to detect real signals versus the false alarm. For example, if you have a sudden increase in fever with rash in two districts, there can be a possible measles cluster. It has to be verified first and fast. So such sort of verification, even when the data flows in, that helps to save time. Uh, that helps you to stay in control of the information and also the situation, because one media report is all that it takes to flare the whole political and administrative system into a huge push, and to have tremendous stress on the health systems to react. So a reaction is not what we need. We need to have an prepared, uh, I would say staggered, measured health response, which is actually cross sectoral and very very prepared. Again, There is a technology backbone that currently India and many countries have. There are mobile applications for ANMs or ASHA. These are our Indian field workers who report case daily. And then there are field teams that review these dashboards and send immediate alerts for spike. So these come into real-time system within the system. And earlier is not too back into history, it's just 3 or 4 years. So now, because of these mobile applications, there is real-time information that is fed from the district to the state, and there is no possibility of an outbreak being, or a cluster being hidden down or, not responded to. Again, the regional sharing of data to track cross-border data, for something like cross-district and cross-border data is vital. And we have seen it happen in many ways now. So again, for a leadership role, we must ensure that data moves up the chain from block, that is the smallest regional district in any to state to national, while field teams also get feedback. For example, in Bihar, where we had a huge AES outbreak, the AES data was looped back to the community using a community participation design, so that they knew what is happening in each of the districts and each of the blocks and where government is focusing on. And it was transparent enough to set community accountability for governance system. So a key challenge here, what I have observed, is still underreporting or fake data reporting. So something that we must do is strong monitoring, periodic audits, and community cross checks to solve it. So this is where I think modern data can help. Coming to the next thing, I just wanted to touch upon some advanced applications of event and syndromic based surveillance, as I noted before. So event-based surveillance is pretty critical where the formal reporting lacks. So here is where we need feeding in from news stories, social media chatter, and local rumors. I don't want to name the countries, but in Middle East, all your social media chatter is monitored. And prominent Southeast or South Asian country controls all its media, so it's easy to pick up media chatter. But in many countries of Middle East, there are health surveillances that goes on through social media chatter. People looking at what being searched on Google, and if you actually Google the symptoms of your illness, I don't feel well, I have a headache, and what should I take, or what is the nearest doctor who I can see for a headache and plus fever. The At the back end, you are looking for a doctor to visit or to consult, but then and reporting your syndromes maybe to chat gpt and other chat boxes to look at information and feedback. But then that information is actually picked up by the health systems, and then you are actually picking up, or you are setting up a trigger for the health system to say maybe there is a case of fever with headache and you should be monitoring this cluster. Another example is like there are systems in Malaysia and in Singapore, where villagers can alert a block health officer about sudden poultry deaths anonymously. So they have an VRC, a voice activated response system, where you can just call a set number and said, "Look, there are hens dying here in my neighbor's house. So I think you should come and visit." So they don't ask for your number and they don't even store your number. So any such calls actually sets off an avian influenza investigation, because avian influenza is a huge thing because of the economic dependence on poultry. So whenever they get a case, it actually leads to culling of a large number of poultry and hens, and it sets their economy by quite a percentage. So something like an anonymous voice activated response system is of huge value there. Again, syndromic surveillance, as I earlier said, uh, these actually track patterns of symptoms before the lab results confirm you what is the fever. For example, a rise in fever with cough that actually signals influenza clusters, and this helps to detect unusual spikes of cases. So, one key practical tip is that we need to tell and teach our field trips to train local health workers and ashas to notice unusual illness and not wait for confirmation. As senior leaders and public health managers, we must set clear thresholds for when syndromic signals must trigger an RRT deployment. In India, an example here is we have a trigger point for severe acute respiratory infections in hospitals where data clearly flows regularly to detect emerging flu trends, where you can actually tell them if a new flu strain is actually prowling across. So again, the next thing I would like to touch upon is digital tools and real-time data sharing. And modern outbreak response today is mobile or IT based and uses cloud-based reporting for accuracy as well as speed. So, if you are in India, you would know that there was an Arogya Setu app that talked about, if you are well, if you are having symptoms, and if you can book a ticket, and if people around you are actually COVID positive, there can that used to trigger off an alert that there are people around you who have reported COVID positive. They have gotten tested, so please do not step out. Or even if you step out, you would need to actually, use a mask. So again, this Arogya Setu app developed something into if you are tested COVID positive, you would be assumed as a COVID case and you would not actually get to travel. There would be a quarantine on you, and you can't actually, if you need to travel and use the public health transport system, you would need to be cured. And actually, your cure status must be reflected in the Arogya Setu app. So that will allow you to travel across outside of your city or district. Now, field teams also use apps like GoData, that is the WHO plugin for contact tracing and chain mapping and of exposure. The new things, I wouldn't say new, GIS has always been around. We have just now used it for real-time data sharing in a layered process. So this actually tells you how many clusters are there for in real time. For example, you can make what is technically called closed pleth map, or popularly called a heat map for dengue spot map by word by what. So one thing that I would need to caution here is data sharing across uh, with other agencies and with higher sectors. You must balance the speed with security. Whenever data is shared, you have to remember, or we must all be cautioned that this is patient data that we are sharing, and individual's privacy that he has all rights to. So whenever are sharing patient data, it has to be anonymized, encrypted, and needs to be stored on secure servers. I'm telling this from personal experience because a large chunk of data actually was siphoned off from a popular tertiary care multi-center hospital in India. uh, so we came to know that there was also a blackmail process, and then the government of India did not yield to it. But then it happens that if you have a centralized unsecured database, all database can be spoofed off onto non-state actors and can lead or can be used for non-fair purposes. Again, one thing we must learn to do is to push for interoperability. Our lab systems, our hospital electronic medical records, and the public health dashboards. We know that in our countries and our systems, they don't talk to each other. These are siloed and separate systems that actually don't have an API that can actually link up to each other and talk. So this is the world and time of interoperability and collaborations, and this is where we must actually aspire to be. So a challenge is the geography still, and then the digital divide or the staggered use and uptake of technology. So this is also quite workable. We just need to think about the problem in with several hats on our heads. So one thing that we can try out is to plan offline data that can actually sync with real-time dashboards at a later date when you go to an area where you actually have an internet network. So there are several things and several challenges, but then the approach is to have an open mind and think across your own sector and see how data can be shared in a safe, fair, and anonymized manner. So again, this is where I want to touch upon One Health in detail and the cross-border and multi-sectoral surveillance required for One Health. So the problem with diseases and pathogens and outbreaks, we have state borders, we have a sense of time, but pathogens don't have borders. Zoonotic diseases like Nipah, avian influenza, and anthrax don't respect the line that humans have drawn on the map of the world and say this country, this state, this county, or this district. This is where the case is. For example, India Bangladesh cross border data sharing for Nipah virus surveillance in bats and pigs today isn't reality because we realize that there is a huge possibility that viruses can actually cross over from borders to borders. This also means a strong thrust on multi-sectoral approaches that actually means we need to work alongside animal husbandry, wildlife, forestry, and environment. For example, in India, there is a localized disease, but highly mortal disease called Casimir forest disease. So here, monkey deaths actually signal the risk zones, and the unless the veterinary and the wildlife department tells the human health department when the first monkey death occurs that the virus has become active and we need active surveillance on those areas. So this is something that needs to happen locally, but this is being actually advocated at a global level, where global bodies like WHO, FAO, and Organization for Animal Health have started to connect human and animal health data for One Health surveillance. We as senior leaders, we need to build formal MOUs with reaching out to our animal husbandry counterparts, environmental departments, and also the ministries of environment and forest for routine data exchange. A quick scenario in this regard would be whenever poultry deaths are reported, the veterinary team tests the birds, the health team screens the villagers, and we have a quick culling done to prevent large outbreaks in an informed fashion. So the farmer needs to be compensated for his livestock and poultry, and we need to ensure that he is part of the system and is well informed. Again, another example is that the rabies elimination projects that pilot integrated dog vaccination with human campaigns. So such things have actually helped become one of the Indian states, Goa, which is quite famous outside of India too, to have an eradication platform which is still working on. Goa is one of the earliest, and I believe it is still one state where dog bite mediated rabies have been eliminated. So these are some examples that that we can all do, we can all aspire to and work towards. So one system, one prerequisite for all of this is data. So while I talk about data, people say data is the new oil. There is a huge and tremendous uh, potential for data, for the use of data and the misuse of data. So data is only useful if it is timely, complete, and accurate. because sloppy reports can actually hide outbreaks. A delay of example, a delay of 3 days in reporting clustered deaths can actually help the virus in spreading across households into the community and even across districts and into the states. We need to ensure that our level, that at the field level, the first thing to ensure is the daily line lists that come across onto our desk has all the complete information, the correct information, and the collated information. I always say the three C's: complete, correct, and collated information, which actually is quite simple. It must have the name, age, location, onset, and lab status. And whatever is your the comments as part of your informed eye at the field level, that also needs to be recorded. You also need routine cross checks, uh, a reported line list must tally with the lab confirmed cases. These are particularly important where people share common surnames. There are too many names. Like if you are conversant with Bollywood films, I would say Rahul is almost Shah Rukh Khan's usual name in all of the movies that he acts in. So that is quite common for anywhere in India. There are common names across. So you need to actually have some sort of verification across. And if you are able to use an automated threshold alert, for example, if you have set a threshold alert for weekly diarrhea cases that actually has been taken care based on cross seasonal average, that can help trigger an investigation whenever that threshold is actually breached. And regular updates that help you detect fake reporting. For example, if you are in the vicinity and you're going on a duty tour, please check the PHC register to see how many patients are actually there in a doctor's OP, to see if the register actually matches digital reports. So whenever a district or a state or a national level officer can actually go to the field and verify data, this is the best method that tells your whole system that yes, there is an active audit by the officers. And also incentivize accuracy. So most of the health systems are, you know, uh, living in a state of constant fear, because if you report it, it becomes a political issue. And somewhere along the line, people also think there are diseases because you have been inactive, you have not taken action, or you have not done your duty. You primarily have to communicate to your communities and administrators that irrespective of whatever you do, there will be diseases, because these are pathogens much smarter, much sharper than human beings, and they always find a way to attack you. This is a question of survival for them. For you, it's just a matter of health. And, mostly 3 to 5 days of paid leave or unpaid leave or hospitalization. But for pathogens, you always have to remember it is a question of survival for them. And they will find ways to come and attack the human race in various ways and forms. So, next thing I would like to talk about formally some recent developments that have happened. So, the One Health Joint Plan of Action is currently in place from 2022. It was launched by the quadripartite organizations, Food and Agriculture Law Organization, UNEP, World Organization for Animal Health, and WHO. This is actually built upon 6 interdependent action tracks that collectively contribute to achieving sustainable health and food systems, reduced global health threats, and improved ecosystem management. So this is one of the guiding principles that the National One Health Mission that has just been launched 1 year across in India is working under. So these are the 6 action tracks of One Health. So action track 1 is actually talking about enhancing, uh, One Health capacities to strengthen health system. Action track 2 is talking about reducing the risk from emerging and re-emerging zoonotic epidemics and pandemics. Track 3 talks about controlling and eliminating zoonotic, neglected tropical and vector-borne diseases. Action 4 is about the assessment, management, and communication of food safety risk. Action 5 is about the AMR risk that the world and every country is starting to face today. And action six is integrating the environment. In most cases, this is the forest, the climate change being also included, and to have it included in One Health. I also want to touch upon the International Pathogen Surveillance Network because it is a global network of pathogen genomic actors that is the cutting edge here today. So this is brought together the WHO hub for pandemic and epidemic intelligence to accelerate progress in pathogen genomics and to improve public health decision making. So the vision here is that a world where every country has equitable access to have a sustained capacity in itself for genomic sequencing and also analytics. Bioinformatic analytics is one of the trickiest part to actually tell you what we have sequenced as part of its public health systems. So the mission is to have a mutually supportive global network for pathogen genomic surveillance. One important thing is while WHO had said that there is a huge opportunity for the global South to come across and work together for a South-South based pathogen genomic surveillance system that amplifies and accelerates the work of its members to improve access and equity. Again, there is this Africa CDC strategic plan that in the global south that we have seen. So this is to become a world-class, self-sustaining, agile institution that talks about health security, uh, sets the African public health agenda and leads and coordinates continental approaches driven by a One Health approach. So here you have an example of unified common strategy that are localized but integrated across traits and uses and One Health approach. The WHO also has started to talk about collaborative surveillance. So, under the what defined architecture for collaborative surveillance, WHO in 2022 uh, touched upon how to have an effective prevention plan, preparation plan, detection plan, response, and recovery plan from health emergencies at all levels of government, the subnational level, national, regional, and global level, for based on the operational readiness and capacities in 5 interconnect systems. So it talked about collaborative surveillance that we have touched and we have discussed, community protection, this as safe and scalable clinical care, because we as public health leaders are on one end of the spectrum and clinical care for individual patients are on the other end of the spectrum. We must also have equitable, fair, and equal access to countermeasures. And at the end of the day, it all comes down to emergency coordination at the field level, where each of us must respond and respond now for an coordinated action. So, this collaborative surveillance is systematic strengthening. So it not only involves health sector, as I earlier said, animal, human health sector, but it can also move out of the traditional ambience of health and include education, industry, and transport, because these are the non-traditional but bearing upon heavily on health sectors that come up. So an approach here would be to have a specific threat or risk approach where you already clearly have identified what are your risks, and then you already have are making the healthcare and veterinary service access together into it, and then you have other insights coming in. So these is an integrated surveillance platform where where this is an integrated surveillance system, and these are other vertical and specialized surveillance that actually built into it. This is our scope of integration, where you can actually put together an integrated framework into the ongoing systems. I'm not saying this is an easy work. You actually have to convince policymakers of, of the positives or the potential of an integrated collaborative surveillance, there will be challenges and resistance from silos that are already built, because people are perfectly happy working in their own cocoon, in their own systems. But then to break those systems and to talk to each other without egos, without departmental issues, that is where the true challenge comes in. Again, the latest development on this front, the global development, is regarding the pandemic agreement. The member states of WHO have adapted by consensus the first pandemic agreement that happened in 20th March. So I was fortunate enough to be part of the consultations for the Indian government in the last three rounds. So it was 2 week processes. There used to be changes in the text, even a single word like, if you example the first pandemic agreement, there used to be at least 1 or 2 hours of discussion. Should you call it the first? I mean, it is the first, but should you call it the first pandemic agreement in the agreement itself? uh, there used to be at least 2 to 3 hours of discussions in the several parties, and to reach a consensus, that used to take minimum at least 2 to 3 weeks of continuous dialogue in the WHO headquarters. And then this is a landmark decision by the 78th World Health Assembly, where, as I said, there were 3 years of intense negotiations that stemmed from the devastating impacts of COVID-19 pandemic to make the world safer, more equitable, and more ready for future pandemic. So again, I would like to touch upon one significant development. People are today looking at wastewater surveillances at travel hubs. Uh, uh, at least I know of 5 countries where airports have uh, been starting to be used with for wastewater. Wastewater from airports and aircraft can be a potential route for AMR transmission and a valuable tool for global AMR surveillance. So this paper from Lancet that talks about the spread of SARS-CoV-2 variants across 5 continents and their flight routes actually tells you that this is the huge cluster of flights from all different areas, and from experience what were the case you know burdens in these countries. So the number of variants detected also corresponds to the highest flight crisscross pathways. These are simple analysis that people have done, and they have told you the busiest airports and busiest regions are also where you have the highest number of variants rising globally. So next, I would like to touch upon the Global Virome project. This is an US-led collaborative institute based at the One Health Institute at UC Davis. The project was launched by EcoHealth Alliance, and the former Chinese Center for Disease Control and Prevention. So this main goal is to identify and prevent future viral outbreaks. So this is centered upon a massive, and when I say massive, it is indeed massive, collection and sequencing of the planet's unknown viruses. So it is estimated that we have massive 1.6 million viral species that are yet to be discovered in mammal and bird population, and around 631,000 to 8 lakh of them have a zoonotic potential. So the cost of identifying these unidentified virus is one major limitation, which would actually take 1.2 billion US dollars. So think about the scale of things if we need to be truly prepared, at least at the genomic level. But then this sort of investigation, this sort of initiative is also required if we have to have medical countermeasures prepared. That is where WHO is also pushing its efforts. There is something called the CORC, the CORC, Collaborative and Open Reporting Networks for Pandemic Preparednesses, that actually talks about viral families and establishing vaccines for viral families, not for particular viruses. India is part of the Paromyxovirus viridae family, and that leads this CORC for global. And I'm happy to inform you that ICMR is the global lead in this direction. So again, the Quad workshop on pandemic preparedness for Indo-Pacific region. So they had their own, all regions had this workshop. So the Quad countries actually came in through in India, and there was a huge talk on how different groups of nations can come together for pandemic preparedness. So I'm just saying these are regional cooperative groups that actually have come in, the Quad countries like India, Japan, Australia, and the US. They came together and have their own small group. This shows how even in a global world, uh, regional state parties can actually leverage their strengths and work together. Again, I would like to give the example of the National One Health Mission in India. It was the Prime Minister's Science, Technology and Innovation Advisory Council, because earlier One Health used to be siloed within various ministries, and we had around at least 8 versions of One Health going on in India at various ministries. So the Indian Council for Medical Research is the implementing agency for the National One Health Mission today, and we have around 1 years of activities that are started off. So one example of where this National One Health Mission works is in implementing an integrated disease surveillance platform. So we have started off here on this note in India, where we have clinical and epi data flowing in from human, livestock, and wildlife. So these are the agencies that are actually mandated to report the IDSP in India. For people in India, you are aware of the IDSP, but not many people are aware of the livestock data that actually has something called a Pashu Aadhaar system, like an Aadhaar ID system. So National Dairy and Livestock Mission actually has data on livestock that has an unique ID number for identifying each cow and each buffalo. It's a wonderful world that they are moving on to. And then again, in 2 to 3 years, we will have something called the National Referral Center for Wildlife. I am part of the talks for setting up a National Referral Center for Wildlife also. And we have a disease portal called IHIP for people who know, that is actually was set up by WHO. This also uses non-traditional data that we have been talking about. We also that the other things that we talked about: airport, sewage, wildlife sentiments. So this also hinges upon newer methodologies for environmental surveillance, lab assays, sampling methodology, and this can be piloted across human, livestock, and wildlife sectors. So this is one activity that the National One Health Mission has been currently working on. So again, the the agenda following this for surveillance is to have an robust outbreak investigation system. As I said, it has to be integrated from national, state, and district. It has been traditionally, and but these silos, the human silo, the livestock silo, the wildlife silo, all has to talk to each other and have an integrated rapid response team at the district level, where all officials work together. So we have set up in India currently something called the NJOT, National Joint Outbreak Response Team, that actually has all the officers pulling in at any signs of an zoonotic outbreak. All these officers from various sectors are actually pulled in for an integrated response and outbreak investigation. So again, for a database, we have been working, or we should work for integrated database that actually tells you uh, different databases feeding in from livestock data, wildlife data, and human data. So in India, this is the Ayushman Bharat Digital Mission for Human Data, the NDLM that I told you, and the National Referral Center for Wildlife from zoos and other sanctuaries and wildlife protected areas. So again, one more area that have come up that has been beautifully explained in this paper. So this is titled "The Framework for Developing and Validating a Dengue Prediction Model" that came up very recently. If you think there is a data collection and processing that is done real time, So they collect climate data for temperature, relative humidity, precipitation, and then the health system collects data for non-climatic uh, predictors like population density, mobility of people, land use, baseline dengue incidents, and interventions. Both of these data is integrated and then analyzed to have a model development. So this is being evaluated constantly, and then it is refined to have the accuracy of multiple models, and this combines the best model onto a final ensemble model that actually tells you with a predictive accuracy of low risk, moderate risk, or high risk, or when an outbreak is can reach up to. So again, EpiWatch is an AI-based outbreak detection tool that was developed by pandemic intelligent researchers, which uses open source media, news, and social media. So you can all subscribe to EpiWatch. If you are part of the government, you can actually ask the government to identify, and subscribe to EpiWatch. So there was an March to July study that identified in 2022, if you watch actually told you that an influenza-like illness actually ahead of the official mycoplasma pneumonia confirmation that actually told you there is an unusual rise. So this shows its value in investing in syndromic surveillance, where that can actually help you prepared for any incoming serious illnesses. Again, I want to touch upon Blue Dot because it's my favorite case study to teach, to talk about when it happens. The first, after COVID broke out, Blue Dot was the first agency that told the world which are the other countries that, you know, the next COVID wave would strike in. Can anybody tell me how it did it? This is a question to the audience. Would anybody like to respond on the chat box or tell us how it did it? So
Okay,
it
Faisal, please
basically,
open
it's
the
not
chat
written
so that
as,
they can respond to it.
yeah,
Thank you.
yes. So I
They had closed
realize the
because they were
first
sending a lot
set
of
of slides have
messages.
been.
Yeah, they were sending a lot
Oh,
of
okay,
messages in the chat, so we closed it. Okay, please open it now.
okay.
Yeah, participants, please, you can put it in the chat. Answer to Dr. Anoop's questions. Now they have started. Okay, do not write good session, bad session. Write the response to Dr. Anoop's question, please. Thank you. The chat is open, participants. Please respond to Dr. Anoop so that we can start.
So Blue
Dr.
Dot,
Anoop, could you please repeat? Yeah. Yeah.
yeah, Blue Dot is a Canadian AI, sort of a startup at that point of time, but it accurately predicted after China, which are the next countries uh, who would be affected by COVID. I'm just wondering if anybody could write in the chat box how they predicted it. Do
Any
you
idea?
have any idea?
Please put in the chat. Okay, they are putting a lot of responses now.
Yeah, I'll take a minute here.
Cluster.
Yeah.
Sure, please. And we'll take a few questions now, Dr. Anup, in case you want to take a 10 minutes break as we
Yes,
discussed,
yes. Yeah,
so that you can respond.
yes. So I'm coming on to that. I just wanted to finish off one block, and then we can take a break.
Sure, sure. No problem.
Yeah.
Okay, they are putting a lot of responses. You can read in the chat. And
Okay. I'm not able to read the chat box.
uh,
Maybe
do
I'll
you
have
want
to
me to
stop
read
the
them?
presentation.
No,
Yeah,
no, no.
that would
I
be
can
great,
read it
sir.
out for you. Yeah, NGS technology integrated with AI and data analysis. I think is basic
Okay.
infection by counting the number of searches
Okay.
online about the ongoing disease, assessed, analyze the circulating strains from the global influenza surveillance network, travel data, mapping travelers' detail from Wuhan, data analysis, scenario analysis, looking for trends in Google search, interact. Uh, yeah, I think that's all.
Yeah. One person
Circulate.
is close. They just close to the right answer. So they just analyze the flight paths from Wuhan to other countries,
Yeah,
and the
any
cross flight pathways of people traveling from Wuhan to other secondary airports and countries. This was a simple thing they did, and they were able to predict where all the other COVID waves would come in. So one of you is right. So congrats on that. But simple things, that actually look at global flight paths or airport paths, travel paths of travelers coming in from an infected area. So these are the things that we can actually set up and have an active surveillance built into. So again, there is a media scanning tool that we have actually talked about. If you want to, this crawls millions of articles online, and this was actually built by an homegrown AI startup that actually integrates AI alerts into official workflows at states and district levels. So yeah, so here I would take a break, and then when you come back, I will start with a short quiz to make sure you're not sleepy on a Saturday evening, just to have your thinking hats again put up.
Yes, definitely. Okay, so I'll read
We
out
can
few
go for a
questions for
break
you.
here, sir. Yeah,
Yes.
yeah.
Right now is a break for Dr. Anoop, but not for the participants. Please keep putting questions in the Q&A. I'll be reading out few important questions which will be helping the training program. Okay. Okay. So the first question comes from Jahanara Begum. She is saying in African countries, diarrheal diseases and death are higher than any country. Top 10 countries where child death due to diarrheal diseases, most of them belong to African countries. What is the plan to reduce child death due to diarrheal diseases? Although this is not primarily infection, but still. That's the question to you. Do you want to respond to that?
Would you like me to answer that now?
Yes, if you would. Yeah, sure.
Yeah. So for diarrheal diseases, there is this globally, I can think of two things. Global Foodborne Infection Network is one thing that the US CDC and WHO together tested out in various countries. In India, it was tested out in Tamil Nadu and Gujarat, where they focused on diarrhea as a syndrome, and they actually teamed up with food safety department, the FSSAI, as it's called in India, and also the local shops and restaurants networks. So they teamed up with the associations also. So that was one brilliant strategy that they did. It was intersectoral collaboration. The first case of diarrhea would be looked into, and if it's a child, an alert would go on to the teacher or the principal of that institutions to see if there are more children being affected. So that is one response that globally, that was an example of globally led GFR network into diarrhea.
Okay, there is another question coming from Ham Shaveni. See, they are asking, hi, may I please know disease outbreak investigation? Will it include only acute illness or even chronic communicable disease like TB?
So it includes chronic communicable diseases also. For example, hepatitis. Whenever it becomes a large scale thing, or even it can also, for your example, it can also be something like a toxic exposure. It can also be a non-infectious. So recently, the ICMR participated in an quite interesting outbreaks of baldness, which was particularly seen in two or three districts in Maharashtra. So it turned out to be an event where there was unknown contamination by and toxic compound that actually led to baldness. So it's not always infectious diseases that triggers a health issue.
Yeah. Okay. Uddin is asking, what's the difference between community-based surveillance and EBS?
So event-based surveillance is actually led by the health system, but it monitors the event. But community-based surveillance, the trigger point and reporting comes from the community and not from the health system. So you need both actually, and community-based actually ensures that community takes ownership of its data, so it's much easier to get them on board towards your response too.
Okay. Right. And Basma Tolba is saying, is there an advanced digital reference system on those applications? I think you have already talked about it.
Yes. So we have talked upon and touched upon this. So I'll also be touching about some more in the subsequent sessions.
Sure. Farah Yasmin is asking emerging trends in outbreak investigation. It is very exciting to see all the scopes and fields. How can someone from an LMIC like Bangladesh actually get into such field? From my observation, there are few opportunities to work in such system. So, are there any programs, organizations, or volunteer opportunities that take early career people who would love real world advice, especially for policy and non-technical roles?
Okay, so there are a few training opportunities for, I wouldn't say LMICs, it's open to everybody, but it's more significant for LMICs. So there is this GOAN network, Global Outbreak Response Network, that is centered in UK, but does periodic workshops for people interested in surveillance and collaborative surveillance activities. So you can look up the GOAN network. They they regionally coordinate with a lot of networks. I'm sure there is a nodal in Bangladesh too. BARC is one organization that I know that is engaged in public health trainings in Bangladesh. Maybe you can reach out to them.
Haruna Lule is asking how efficient is India's cross-district, cross-border data flow or sharing?
See, every system is only as efficient as the people who are managing that. So in India, we have regional differences also. In south and maybe in the west of India, states are more proactive, and it is the governance that sets the agenda. If health is a powerful or a strong, uh, an item of to be focused upon, both economically, politically, and socially. So, if you have strong health systems that are connected within the overall governance framework, that are vibrant and actually focus on health, that's a different story. If you don't have a strong health system, if you don't have people who are strong in the health system, if you don't have trained people, if your recruitment of personnel into the health system is low, that affects it. From my experiences around the world, even when I went to Brazil for training in pandemic preparedness, the story was true. And from my experience in WHO and CDC, uh, what I have seen is it is also the same for advanced countries. So people set up more diligent systems there. So it is irrespective of the people that run the systems in most developed countries, they already have a strong system there. So that is where the critical difference is, as per my observation.
Yes. Then Peter Amide is asking, can you give a practical step-by-step method of putting a surveillance system of Lassa fever or any epidemic-prone disease in place in a LMIC?
Yeah, so setting up any surveillance system is contingent upon three, four systems, three, four principles. So one thing is you want to get the information early, you want to get it fast, and you want to make sure it is the right presentation. So be it for Lassa fever, be it for any disease, first you must have clinicians who can tell you uh, this is a patient of Lassa fever. So definitely that clinical diagnosis comes from that. Second, not only a clinician, but a lab must also be able to tell you. So you need the primer probes, diagnostics to tell you this is a Lassa fever. Second thing, you also need an efficient health system response that can actually stand up and say, we have disease, we have diagnosed a new fever. I'm telling you from field experience from the Nipah outbreak in Kerala, where there was a little bit of political pressure not to say this is a new viral fever of huge consequences. How dare you report it? So these are fundamental things for a medical diagnostic, and then for an administrative and political diagnosis to say, yes, we have a new disease, we need to do something upon that. That you need a strong health system, strong political leadership, And of course the strong the education level, the involvement of democracies in having good governance response. So quite a bit of basics are there, but to translate the clinical diagnosis into and political and administrative diagnosis, that chunk must also be plugged in.
Right. Then Laboni Akhtar from Bangladesh is asking, Bangladesh has adopted a One Health strategy that includes coordinated zoonotic disease surveillance and pandemic preparedness. In practical terms, how can nurses and allied health professionals be integrated into this system to improve early warning and response at the community level?
Yeah. So I am aware of the Bangladesh things, and we had talks with them during CP conferences. So nurses can actually report there's unusual syndromes that you see through your hospital-based surveillance systems. So if there is any unusual presentation, you can talk to the clinicians. If you're a community-based nurse, you can actually report it through your uh, uh, disease surveillance programs. I am also aware, I'm not sure in Bangladesh it exists, but private practitioners in India and even the public can report an unusual syndrome or a cluster investigation uh, to an IDSP, and that will be followed up. So there are systems that the surveillance systems have for open reporting from any source. So I am not sure if you have it in Bangladesh, but then if you are a nurse working within the health system, there is a provision. And for private practitioners also, I'm sure there is a provision to report unusual syndromes.
Right. The next question is coming from Shefo. They are asking, Track 5 makes reference to AI. What is the view of the WHO when it comes to AI and disease investigations? Can you elaborate on the role of data management systems in strengthening the disease outbreak controls?
I'll take the second question first. So there is a strong role of AI in strengthening disease investigations, at least at the clinical level. You know that AI has some strong background now for at least chronic diseases like cancers, reporting TB through chest X-ray. There is a huge potential in image analysis using AI that everybody uh, has started to jump the bandwagon. Currently, even ECGs and echocardiogram reports are being read by AI. So that clinical information that will help AI integrate is already there. In public health specifically, AI can actually detect trends across surveillance platform and can compare and train an AI model onto available trends. That is where AI can come in. And I'll take your first question now. What WHO does for integrated surveillance? So WHO is very open upon non-traditional systems or open methods of surveillance now. There is a huge movement that WHO regional offices have been told to and integrate it. And then there is this joint external evaluation on surveillance, the ports of entry. There is this IHR revision, and latest IHR also talks about an One Health approach, a latest change that has gone out from WHO to talk about the One Health approach as well.
Um, Jahanara Begum is asking, in the urban slums, there are so many people who never go to the clinic for test. When they feel any kind of febrile illness, how do we identify if they have COVID-19 or any other disease? What is the plan to include them under One Health program?
So they are already part of the One Health program in a theoretical sense. They are part of the ecosystem, and then so there are so many problems that you can have in urban slums. People leave early. Your hospitals start at 9 o'clock and end by 2 to 3 p.m. The OP ends. For urban people, if you consider opening an OP, like in Cuba, that their OP is like a multi-clinic system that has four multi-clinic systems that are open in the evening from 5 to 6. Even Delhi had a system like that. It was called Mohalla clinics for urban health centers. So then they can attend their job, come back in the evening, and go to the OP and get themselves examined. There is also a system of interactive voice recording where you can call people and explain your symptoms. And if somebody at the other end using technology or even traditional counseling or nursing health practitioner is at the other end, they can tell you if you have serious symptoms or a serious illness, and maybe schedule an appointment on a Saturday or a Sunday or a non-working day. So these are subtle things that the health system can adopt if you think you have a serious problem at this issue. So countries like Sri Lanka have actually taken an adoptive approach, and as I said, Cuba, most of Brazil, they have taken serious, you know, interest in working population and to catering their needs in urban slums and urban population as well.
Okay. There are three questions from a person named Baba Boya. He's from Africa. He's asking, can you
Sir, I couldn't hear the question.
respond to it?
Sir, I couldn't hear the question. Can you come again?
Hello.
Yeah, I couldn't
Yeah.
hear the question, sir. Can you please come again?
Okay. Let me repeat them. Question number one: can you explain the difference between active, passive, sentinel, and syndromic surveillance? Second is, how does contact tracing contribute to controlling the spread of disease during an outbreak? And third is, how can technology improve the efficacy of disease surveillance and outbreak investigations? I think you have been talking about it. Maybe respond a little bit more.
Yeah. So active, passive, and hybrid systems of surveillance and sentinel surveillance. So when the health system goes on and collects information, it is active surveillance. When the patient comes to the health system, it is passive surveillance. That is the short definition. And when you have dedicated centers like hospitals or clinics doing surveillance for one particular syndrome or disease, that is sentinel surveillance. You are a sentinel. You are looking out for that particular syndrome to come in and that you will report it. So that has been a hallmark in HIV or other surveillances. Uh, and these are the prime differences between surveillance. So can you repeat the second and third question?
Yes. The second question is,
Sir, again, I am not able to hear you. I'm not sure if it's an issue. If you can type, I can check the chat box.
Sir is maybe facing some internet issues.
Okay, okay. Can you type the question or can you tell me the question? I can respond now. Hello?
yeah. Hello. Yeah. Apologies. Did you hear my questions?
No, sir. The second and third questions once again.
Okay. How does contact tracing contribute to controlling the spread of disease? Yeah. You can respond to it,
Yeah,
and then I will go there later.
yeah. The contact tracing is very vital in, especially in uh, diseases which have a low reproductive number or an effective, to be, if you want me to be technically right, the effective reproductive number. I mean, what the diseases which spread very quickly, also airborne or diseases which spread through contact, human to human contact. So, contact tracing can actually tell you and help you detect the next wave of case. If you want to look at where all the cases will be coming in, or if you have a significant number of cases already, you can actually backtrace and look at the first case and have an outbreak investigation done to see where it all came from. So there is actually a contact tracing in a forward direction and contact tracing in a backward direction. So these are the two advantages, and this can help you control the cases that can help you set up, plan the health systems in place, and it can also tell you how the disease spread or came in from. This is how contact tracing helps.
Okay. And the third question is, how can technology improve the efficacy of disease surveillance and outbreak investigations?
The technology per se is an aid. I have always maintained this stance. It can tell you things that you ask onto it. So if you employ technology correctly to look at your systems, what technology can do, it can automate certain processes. It can help uh, you to do things faster at a lesser cost and with lesser number of man hours. It will never be able to replace a person sitting in the field or an epidemiologist. So we are all grateful for that. So if you want to make your processes efficient, technology can use and help you do that. It can help you transmit data. It can help you analyze data. It can help your communications come over, but you have to use technology for this case. In my examples, I always tell people about GIS. It was a huge technology when I was a student doing my public health degree. There was a huge hue and cry. You can actually do that, do this, visualize things, look at distances and all. But it did not catch on for infectious disease epidemiology. You can make spot maps. It can tell you geographic differences between regions. But then it had so much of promises, but we are not able to ask the right questions. For technology, what people must be able to deliver is that what are the questions that you want technology to answer? What are the domains that you want it to be faster, quicker, cheaper, more efficient? That is the right use of technology in public health for any domain. If you look at all the world leaders in technology and automation, they would all be telling you the same thing.
Okay. So now we can start again. We can resume your training, Dr. Anup, and then we'll take the rest of the questions at the end. Yeah. Thank you.
Mm.
So participants, please keep
So,
putting questions in the Q&A, and Dr. Anup will resume his training now. Yes, thank you.
yeah. Welcome back. I would like to, now have a Q&A sort of an session where you can use your thinking hats and answer a few questions. So I'll be, looking at the chat box as well and see what are the thoughts that you have for me. So I will now start, sir, with some questions that I think it would be vital for people to answer. So this is the question.
The question,
Which
yes,
virus
sir.
was declared as a public health emergency of international concern most recently by the WHO, and when?
Okay, the chat box is open. Please keep putting. Let's see. Dr. Anup is monitoring the chat box, so please keep putting
Yeah,
responses.
I'm monitoring the chat box.
Yes.
Yeah. Okay, Mpox is where most of you are coming on to. Okay, Mpox. Okay, okay, okay. Yeah, okay.
Okay. Interesting.
Most recent one is where I'm asking. Yeah. Yes, I think we can stop there for want of time. The most
Yes.
common answer has been Mpox, and that is correct. Yeah, thank you. And
Yes.
so, what I want you to think is what are the factors that make a virus or a pathogen declared to be as a public health emergency of international concern? So, Mpox started with a few countries, right? So, why should it be a public health emergency of international concern? Why should all the world take stock of it, and why? I mean, I just want to pick your brains and think about it. I mean, this is for thinking at your leisure time. Next question. So, what are the three main components of international health regulations, IHR 2005, what are the core capacities that countries must develop? It's more like a quiz, and then we think about what are the principles. So there are three main core components in IHR that the IHR thinks that the countries must develop. We are going on to the second question. Question number two is that what are the three main components of the international health regulations core capacities that country must develop?
Please respond to the second question, not the first one. You have to write three. This is about three main components, so you have to write three, not one.
So if you know it, you know it. Otherwise, you don't. So, but then I hope to have sort of, then we can think about, yeah.
Okay, thank you.
Yes.
We can go to the next question now.
Yeah. So most of you, again, it's right. It's prevention, control, and response in some main ways that these are the three core capacities that countries need to be developed for a strong surveillance system. So again, most of you have told me the right answer. Yeah. Again, the third question, let's go on to the third question. Which was the first country to report a human infection with a H5N1 avian influenza? Do we know that? Do you know which was the first country?
Please respond to the third question.
China, Hong Kong, US, DRC.
Maybe you can tell them the response.
Yeah.
Answer.
So the right answer is China to report a human infection with a H5N1 avian influenza. So the problem is that this was the first reporting of a spillover event, and then the kind of onslaught that the country faced to have reported it. So it takes a lot of political, in plain speak words, guts to report it to the world, saying that unfortunately we have found this and this is what we are. If we don't report it, there will be ramifications. But we rather tack the ramifications and then prepare for the huger or the bigger or the dirtier ramifications that come from it, rather than hiding the data. That is what I wanted to talk about. Again, the fourth question that I wanted to touch upon is what global system provides early warnings of outbreaks, uses unofficial sources and media scanning? Any responses? EIOS. Okay. The epidemic intelligence from open sources. So I'm talking about early warnings. AP Watch. Okay. China. No. Global system across the world. Yeah. AP Watch. Something else. AP Watch is good. You are right. I'm looking for one more. No, Blue Dot is an AI. It doesn't offer a global thing. Go Data is again a platform. Yeah. Global Public Health Intelligence Network. No. Has anybody heard of ProMed? That is the word I am looking for. ProMed gives out weekly and public information for early warning of outbreaks from non-traditional sources. So please check out ProMed. ProMed is what I was looking for. Yeah. So can you tell me, the next question is, can you tell me one zoonotic disease that has increased in incidence due to climate change? Can you think from your countries? Yeah. Dengue, yes, agreed. KFV, I'm not sure. Malaria, yes. Is malaria a zoonotic disease? Dengue too, is it actually a zoonotic disease? Yes. Lyme's disease is right. Bird flu
Ev-
again is right.
Everything is a zoonotic
Yes.
disease as long as they remember the name.
Yeah.
They are putting
Okay.
anything that's coming to them.
That's fine.
Rabies is
That's
also
fine.
a zoonotic. Ebola, Lassa fever, dengue,
Yeah.
monkeypox.
Okay. Okay. I think that's good enough. Thank you for your responses. So my intention is, so lot of diseases are actually on the increase due to climate change, and climate change is not real. And what Greta Thunberg may have actually fell off the popularity, and we have been not been the flavor of the month. But then climate change is real. Climate change is here to stay, and we must link up climate change with public health. Only then we will be able to, tell what should happen. So I hope this actually set you back thinking about the issues also. So I will continue. I also wanted to touch upon some advanced outbreak investigation. Uh, Let me just check upon the time once, because I don't want you to be late. So I will end with quickly run through the advanced outbreak investigations. So, there have been steps of outbreak investigations. If you look at the CDC or WHO manual, these are the 9-step framework that are advocated as for outbreak investigations. So, the problems are that early in an outbreak, you have to have an easy, flexible case definition that can be adapted as knowledge grows. For example, COVID-19 started with a fever with a travel history of coming in from an imported country, but then later included asymptomatic contacts and their, ILI and SARI definitions too. So one thing to remember is that syndromic case clusters can actually help detect clusters even before the lab results. So we need to have a probable suspect and confirmed tires clear, and have it communicated to our staff and local authorities and even the labs. So you need something like an adaptive surveillance that keeps the search criteria tweaked as new symptoms emerge. So you should also be updating the case circulars via WhatsApp groups to the public and to the communities that you are actually giving in. So when you develop protocols, we all develop protocols. That is the first thing we do as administrators. Uh, what I want you to think about is it must be field friendly. You must have clear instructions for safe sample collection, data recording. For example, a mobile team investigations, they need strict PPE guidelines and decontamination strips. I also want you to have clear roles set for who would be a team leader, what would be a sample collection data recorder, who would talk to the community, and what each person's role would be. You must also take local realities such as language barriers, and always include a safety plan for teams in conflict zones or remote forests. Always plan with enough money for backup transportation, And then sample cold chain maintenance. For example, if you have a work at like we started out with, you must always plan for things like that. So when you also talked about advanced collection tools and mobile applications, you can use mobile tools to solve out this. There are modern tools available like ODK, EpiCollect, and GoData. So many of them work offline too. You can actually combine these with lab apps and to have an auto updated list that integrates lab information and field level information. So, for a critical important component of this is training. Your field staff must know how to troubleshoot applications and to avoid duplications. There must be a centralized person who looks at the data periodically and avoids them. So, again, an integration of spot maps, epi curves, and GAS integration. So epi curves show the disease dynamics as they spread. The spot maps help to see clusters. And today you have GIS tools that help you to layer in multiple risks. What are the flood zone? What are the vector habitats, population density, and degree? So we need to start using these visuals to brief our administrators, ministers, media, and to coordinate resources. So a picture tells a thousand story. I always say that. So learn to use this epi curves, spot maps, and GIS into your one-page briefings or two-page briefings when you go to your administrators or ministers. They actually understand what they see in form of a figure rather than our traditional forms of tables or what you write pages after pages of text. Again, there are multiple advanced statistical methods in outbreak analysis currently, like attack rate that go beyond, RRs or ORs. Today we have basic reproductive number, effective reproductive number. We have so much of software packages like EpiInfo, R, and Python that can help forecast what you need and what is happening from the field. So one thing I want to caution you is that data is only part of the puzzle, and it does not provide the answer to the full puzzle. Always interpret statistics in the field context and make sure you understand the full story that comes around what your data is trying to tell. So you also need to have lab coordination and rapid diagnostics. So, a delayed lab confirmation may actually cost lives. So, and then the example is a Nipah virus. So we coordinated quickly with VRDL network when we had the first Nipah outbreak. So your field team should first know where to send the samples. Where is the cholera lab in your country that can do a cholera test? Where is the dengue labs? How to pack them, how to maintain a cold chain. And then the health system must also establish point of care testing at PHC or the lower level tier of health system to cut time. The senior leaders must also establish a turnaround time and SOPs for sample transport. For example, in India, at one point of time, COVID test turnaround time used to be under 24 hours. That used to be the pace where the health system worked. So there are also, somebody asked about contact tracing. What are the examples? So one thing is that there are digital tools today that help bridge the gap where manual tracing alone can't help. So high caseloads require some sort of prioritization. Again, as I said, you have to have privacy concerns taken into your systems. The community pushback that some rumors, if you actually go around and mark certain families or households as affected, uh, you know, that can actually fall back or you can hit back against the health system itself. We had severe backlashes from the community during COVID when people went around and marked houses as COVID positive. So we, as senior leaders, we need to monitor the tracing activity daily, clear the backlog, and adjust your field teams dynamically to see how best we can do them. And always, always remember there is social stigma is real. You and I also face it. In fact, our when I in COVID time, my whole flat building was cordoned off because somebody was COVID positive, and I had to get special permissions even to go out and do our COVID investigations in other states. So stigma is quite real. It's not perceived, and we have to have steps to deal with stigma. One thing I want you to be clear is risk communication and how to engage communities. So, a clear, consistent messages actually calms the public. You can have daily updates on what is happening. You can have a community radio and daily press releases. So, also engage trusted people, local leaders, religious heads, or teachers. And whenever you send out a message, avoid jargons, pre-test the message, use the local language, use the sentence structures that people actually understand, and counter misinformation quickly. You have to have a media team to monitor the fake forwards in WhatsApp, in Telegram, and send out information from trusted sources from the ministry itself. So you know that transparency builds trust. Share what you know. Tell them at this point what you don't know, and tell them what you are going to do to get that information that you don't have currently. So again, the I have talked about this, so I'll be skipping it. You need intersectoral coordination. You need to fix roles at every level to actually tell people what each step would be, each system would be doing. So again, I would like to tell you about large-scale zoonotic outbreaks. The Nipah outbreak, the index patient was linked to fruit bats. The RRTs were there, but then the animal husbandry tested the livestock. The forest department mapped out the bat roost. There were risk communication groups which included local leaders. There was a post-outbreak BSL-3 that was built. So the learning here is that animal-human interface must be part of routine surveillance. It is just not set up in crisis mode. It won't work like that. So again, I don't want to go into lack of time. Field epidemiology challenges and mitigation. Maybe we can take another session on it. I would like to run through the slides, I mean skip through the slides and come to this where future directions and policy leaderships. I think this is one important section that you must be aware of. So we need to strengthen national architecture wherever whichever country we are in. We need to expand the scope. We need dashboards to have accessible to block level officers. We need a sustained funding for that. Outbreak response is not a one-time cost. We also need to push for legal powers within the health system. We need to enforce reporting, quarantine if required. The integrated health information platform in India is a good start, but at local level, we also need that we have sufficient powers to enforce certain strictures wherever possible. So we must integrate One Health into policy and practice. We need to have state level uh, or division level One Health teams. We need to have joint surveillance protocols, and we need to be training together. The veterinarian, the human doctor, the environmental science team need to have integrated trainings, simulation exercises, tabletop exercises that we can do. You also need somewhere down the line, you need international networks, you need tie-ups with international agencies, and funding must reflect the One Health priorities. Most of us, I realize, would be human health uh, stakeholders, but we also need to realize that One Health or our health is not just human health, it's also animal health and environmental health in the long run. Again, the innovations that are currently there using AI, genomic surveillance, some sort of citizen crowdsourcing, like self-reporting groups. You can have an app for them to flag new symptoms. The bottom line is you need to combine human insight and technology. As I said, technology will not replace what the human insight can do. So definitely your field team will live on and the human mind will live on. The leadership roles in preparedness and rapid response. So you must have pre-approved emergency procurement. You need to have your testing kit, your PPE, your mask in place. You must already have built connections with the local administration, panchayats we call them in India, for mobilizing communities. You need to advocate for policies in your respective countries that support flexibility, not red tapeism or delays while responding to an outbreak. And have simulations. Test out your plans every year. Have tabletop exercises and field drills. See how your plans work in the field and see what were the shortcomings. You need to remember good leaders also train successors. You need to train your next generation, so your institutional memory would survive your transfer or your retirement only if you train the next generation who would take over you. So a leader must have a successor already when he is a leader. That needs to be identified on time. You also need to build resilient health systems with good workforce, supplies, partnership, that you need to have a climatic lens. And resilience means there is no single point of failure. You always need to be coming back from what you have learned. So this is my closing session. So I would like to close with saying early detection and rapid investigations equals life saved. Uh, Clear coordination prevents the blame games and saves community lives. Trust is the currency in health system. Build it with communities, media, and other sectors. Invest in people, not just in technology. Your trained human being remains the backbone of your health system, and crises are test of leadership. So, as senior public health and lab and health systems professionals, we must act with transparency, but also with a certain humility that we can be wrong too, but act swiftly and surely. Act for sure. So some thing do's and don'ts that are think for leadership in outbreak response are: trust the field data, not just the top level accumulated numbers. Visit the field area, lead them from the front. Your team and your people will respect you. Do push for intersectoral cooperation, break the silos, take the first step, offer the first handshake, and see what a load of a difference it makes. Don't underreport or delay the tough news. It eventually catches on or goes out. Today's social media is very powerful. It somebody doing a recording while a meeting is going on or leaking the news is very common in all of our communities. Don't dismiss the community concerns. It will come back and bite you at some point of time. And first thing, don't ignore feedback from junior field staff. They have seen the reality first and they are reporting it to you. So don't ignore critical feedback. So this is all from my end. I have just taken 2 more minutes of my allotted time, and thank you for your very patient with hearing. Over from me.
Okay, wonderful. Right on time. Excellent. Okay, so this is my pleasure to now to before we close, there are a few questions which I would read out now for you, Dr. Anoop, and as per the tradition, this is a little bit of moderated question answer. I'll be basically taking out few questions because there is a barrage of questions here, so you can't take all the questions obviously. So I'll read out few questions for you and please try to answer them as many as possible in the next 30 minutes. And
Yeah, I'll do that. Yeah, I will
okay,
also
so
just briefly type
the
out
first
my
question
email
is
address.
from Nela Ntumba from Africa. Yeah, you can share that. We will share it with all the participants also, so not an issue. Um, and another thing we'll do is we'll compile all the questions and we'll send it to you, so you can respond to them whenever you are free, and then we'll communicate to all the participants in the follow-up. Okay, See, they're saying that we have big issues here in Congo on data management during the outbreak investigation, and update of line list to follow the alerts and suspect cases during outbreak, especially if there are many at the same time. Could you propose a model to follow for the improvement of the data quality? Thank you.
Yeah, that's a good question. See, data quality is quite critical. So, one thing to ensure data quality is when you collect data using forms, use platforms like ODK. Traditionally, even many surveillance systems started out with an Excel system that goes in from the field to district level to state level, and go forth. But then, if you use electronic data system, the quality of data can be improved because you have drop down boxes, you have a uniform system of spelling. You can actually cross check the data along with the coordinates. You don't have to include the pin codes. So I think somewhere the digital technology helps a lot. And you can have a structured system of data collection that you can build in that ensures quality at many different levels. Any more questions?
Okay. The next question is from Chandrima Das. She is asking, One Health indicates holistic health for all. The the rice or other staples we eat are grown using chemical fertilizer, which sorry. The question is from Chandrima Das, and she is asking, One Health indicates for holistic health for all. The rice.
Hello. I think Professor Satpathy, there is some connection issue.
Yeah, sir is maybe facing some internet issues. So the question was One Health
Yeah.
indicates for holistic health for all, the rice or other staple we eat are grown using chemical fertilizer, which has health implications. So is shifting to natural farming is better, but that would yield less production, and those who grow rice or do cultivation needs financial security. So what could be the alternative approaches for such instance?
See, I have always advocated for local solutions for local problems. So this specific farm agriculture practice is something that you don't have enough evidence upon. So this is where research comes into picture, and you must explore what are the other available technologies. Maybe something like going back to organic would be a good practice, but then it affects your overall scale. Maybe you can have something like an hybrid technology, but then it is not natural. It has some degree of artificial technology and adaptation evolved. But what is realistic? What is nutritious? What can be applied for a society at large? That needs some research, right? You need safety. You also need some degree of economic viability. So that is an ecological research question that has to be developed and answered. So this is where research can give answers apart from the traditional research domain. So this is an example of an integrated research through One Health paradigm that you can actually see what are the problems and what are the nutritional implications, how can one give it via the public health system and things like that.
Okay. The next question is from Marsad Ibn Mohiuddin. Yes, in a country like Bangladesh, where the public health infrastructure is weak and data from rural villages is sparse and unstructured, based on Dr. Anoop Velayudhan's experience in setting up surveillance and public health systems in similar contexts, where should we to improve the rural health data collection and system development?
Yeah. See, I wouldn't call the Bangladesh data system weak. It is robust, but there are problems, as in every country, in the completeness of certain pockets. There is always an issue from some regions. There is some incorrect data that flows in. So this is an internal audit issue, and you can actually train, retrain, and retain the manpower. You also have recruitment issues, which I'm aware of. So one thing is that data collection practices can be standardized, and you can have a system of zero reporting across countries, and zero reporting needs to be verified through field investigations or field visits. And certain sectors or certain regions that are actually reporting poorly, though these need to be pulled up. And recruitment issues, as I've told you, don't think some of us are weak. When some of us are weak, all of us are weak, right? So even the best placed countries, even European countries, have issues, but they have strong systems that they have built in place. That is their strength. And if you look at the population in the so-called developed countries, they don't have a population challenge. Unfortunately, people in the global south, most of us have a population challenge, and that is a scale problem. If you just look across some developed country and a bustling city, you hardly see people on the road. While in India or in Bangladesh, the sense of population is actually bursting across like the veins of blood in the cities. So you have to realize and the thing from a perspective. I think most countries are we are doing well considering the populations we have in global south.
Okay. The next question is from Deepak Jayakumar. What are the measures or interventions being taken by the Indian government to curb the overuse and misuse of antibiotics across sectors, both human and veterinary? What parameters are being used to evaluate whether the One Health approach is working for mitigating AMR in the country?
Yeah, thank you. So One Health approach is a new thing. We don't have any parameters to for as a regulatory framework or indicator currently. But you do know, if you are from India, that Schedule H drugs are not available over the counter unless you have a prescription. And then there are national antibiotic regulatory programs. There is a national AMR stewardship program that is run from AIMS and ICMR. So it also collects data from hospitals to see what are antibiotic prescription practices and what sort of antibiotic resistance is coming up from ICUs and from surgical wounds and PAPs. So these are the things that is currently going on in the AMR sector.
Okay. And the next question is from Dr. Bishmaya RP. They're asking, sir, I am currently working as a block epidemiologist, a newly introduced role in Kerala. I have observed that field level data is not often reported completely, which affects the overall quality of surveillance. I would appreciate your guidance on how to strengthen the existing surveillance system and effective methods for identifying trends, improving monitoring, and predicting potential outcomes.
Yeah. So the first thing is to report data. Whenever you report data, so some things you may not get conveyed from a block level to district level. So make sure you report it regularly. And you see, in government health system, all that we can do is to do our duty diligently every time we can. So in Kerala, I don't think reporting has a major issue. Most of the reports are now real time and quick. But if at all you have a problem, one thing I definitely advise people is to put it in writing. If at all you have an issue in reporting and speaking out, put it in writing to your seniors, and it is not like a whistleblower thing. It is just saying that you have data and you have reported, you have done your duty, so that tomorrow it is not contingent upon you to say that you have not worked on your level. So write to your higher ups and authorities saying that this is the data you're seeing. You don't need to be embarrassed for that. In fact, that is the whole thing of you getting paid for. So there might be communication issues upstairs, but then make sure you communicate what you want to say. Any more questions? So I'm writing in my, I'm not sure if the chat box is open. Can one of the organizers help me?
Yeah, chat box is open. So another question is from Abu Bakr
Okay.
Abdul Karim, that what are the epidemiological parameters or approach used to determine the feasibility of eliminating a given outbreak over a specified period of time? For example, when there is an outbreak, it can be declared that the outbreak will be controlled over a period of time. What measures are used to make such a declaration?
See, there are no specified methods to say this outbreak will end. As I told you, you are fighting against a pathogen. You are fighting against a microbe that is fighting for the surveillance. So you can end an outbreak any day administratively. If you stop testing, if you stop reporting, your outbreak has stopped. But in practical sense, you are fighting an outbreak with your thinking. What the experience of disease response you have as a clinician, as a public health person, or everything. But see, a virus with almost one strand of RNA can put all your plans to fail. So you can't actually say this outbreak will end or this will thing. My approach, and I think an epidemiologist approach, has to be to see how quickly and efficiently we can work to bring down the outbreak. There are classical examples of outbreaks that are recurrent across years. In fact, I have been following up the AES outbreaks in Bihar from 2013 and 2008, 2005, where when the outbreak started, 2008, you had huge outbreaks. And somewhere in 2014 is when you had a breakthrough when you said lychees are the cause for encephalitis, and it was hypoglycemic encephalitis that actually happened in Gujarat and not infectious. So you can't put an outbreak or say end to an outbreak through any artificial means. When the cases come down, when you implement strong interventions, most outbreaks die down.
Okay. So another question is from Shudin Abu Bakr Abiola, that hello, I am Abu Bakr from Nigeria. I would love to know the challenges with people trusting surveillance systems where they report disease outbreaks, particularly on self-reporting, and how anonymous reporting plays a role. And secondly, during the COVID-19 outbreak from 2019 to 2021, most Republican states in the United States did not trust the government and also felt the government impeded their movement and livelihood. So how can the government develop trust with citizens during an outbreak or an epidemic?
Yes. So the first thing is it governments face a backlash when media reports an outbreak faster than the government declares them. So I believe, it is my personal opinion, that all health systems must report even case clusters as early as possible, and then urge the public to respond directly to the health system. States or health systems that have done this are successful. They have had accountability and trust from the democracies. So the first thing is to say that there is an outbreak. The second thing is to act on the interventions and tell the people what you're doing. It would be useful to have and field presence. If there is a van or a lab, mobile lab that you can send to the field, it actually tells to the public about how serious you are. That actually is a visual cue for the whole public that the government is on the field and doing something. So again, field teams visiting the area, fogging, for I'm not going to name the country or a state, but whatever outbreak happened in a certain state, in a certain country, there used to be fogging. But then people told me fogging was one response that they could easily do. And it seemed like the government was doing something to stop that outbreak. And that was a response. So please take some sort of action in the field and tell the people about what actually you're doing for the outbreak. As I told you, tell them what you know, tell them honestly, tell them first, and then tell them what you don't know, tell them what you're working to do to know, to get from you don't know to you know. And in COVID, nobody knew. So that is one example that people can actually take. People know that you at one given point of time regarding emerging or re-emerging diseases, you can't have all the information. So tell them that scientists are working on it. Your health system is looking for data. You're talking to other people. Your scientists are working on the problem, and then you will have the solution soon. That actually works out in the long term.
So, as you said about surveillance, so another question from Pratik Pasi. During an outbreak of, of a novel respiratory illness in a densely populated urban slum, initial case investigations suggest a high attack rate among young adults, but lower rates in children and the elderly. However, laboratory confirmation is delayed, and rumors of a deadly plague spread rapidly through social media, causing panic and large-scale migration out of the area. So, how would we design an effective surveillance and field investigation strategy in this scenario to confirm the source, control the spread, and manage misinformation while ensuring ethical considerations and minimizing harm to the community?
Yeah, thank you for this question. It actually feels like a Viva question for me. But then these are different variances and variables that you have put together into one question. So I'm sure you have a team, whoever has asked that question. Please dissect out all the variables playing into it and look at the resources that you have. Address the low hanging fruit first. What you told about migration coming out and the social media disinformation. Make sure you reach out to the communities directly. And one thing to have is not be overwhelmed by too many challenges at one point of time. So I don't know if this was a true scenario or that was sort of an and simulated scenario. But the answer to eating an elephant, as people have always taught me, how to eat an elephant. It's a big problem. It's a huge problem. I always tell back bit by bit. Take your first bite first, the second bite, and then bites after bites after bite. Break down your problem into small chunks. Address each one of them. Address the first critical one. Address the chain that connects the first chain to the small chain. Bring in people if you don't have all the answers. Ask questions to your seniors. Reach out to other scientists or researchers in other countries, and then build an integrated approach.
Okay, one question comes from Ramya V. She asks, what can be done to channelize the whole health information of an individual throughout? In my opinion, the different departments are updating the information in multiple applications that can be streamlined to one application to decrease the burden of their work. Can you please elaborate what can be done to channelize them through government?
So, if you are in India, this is already happening. So, IHIP will integrate information from the animal health sector. So, eventually, it will also integrate programs from hospital-based EMR, the Ayushman Bharat sector. It will also integrate the animal health data and the environmental data. So, that sort of integration has some hitches by way of technology, but more of the issue is from the sectors themselves to share data openly, to share information across in case there is different. So this usually happens on two scenarios. One, uh, you don't trust the information you have within your system. Two, you don't trust the other guy to keep the information to yourself. Three, you actually don't trust that they would share back the actions that they did, or maybe have a publication from your data and don't include you. I mean, honestly, that is what we are afraid of, right? So if you have a system where it is a perfect give and take, you have an integrated system of credit sharing, you talk to the people in an integrated fashion, you also act and train together, then you won't have a problem.
Okay. The next question comes from Jaharuddin Mustafa. She is saying, "Hello, I am Mustafa Jaharuddin from Nigeria. What are the most effective community level strategies for early detection and response to infectious disease outbreaks, especially in resource limited settings?"
Yeah. So in community research settings, there have been enough research, at least in India, to see what can be the models. So you can identify community leaders. These can be community health workers, or school headmistresses, or the principal. Uh, and then from communities, it can be community leaders, or faith-based organization leaders. So they can actually report a case of, or a peculiar syndrome, or a syndrome, or a set of symptoms if in case of a new disease. So they can be trained on a reporting system that can go back into the health system. So such experiments, such interventions have been tried in south of India, and they have worked. So community-based information reporting is actually a very vital tool that actually helps.
Okay. Right. The
Can I
next
take two
question.
more questions?
Yeah, sure.
Yeah.
Sure. Uh, the next question comes from Uche Ebenezer. They are asking, why were health systems in Africa and in some parts of Asia designed originally to fail and poorly adapt to emergencies? Was this deliberate to drive colonization, or was it poor concept of public health by our forefathers? How can emerging African and Asian scientists, in the midst of mistrust and misaligned funding priorities, reshape their health systems? Interesting question.
That's pretty interesting. Yeah, very interesting question, sir. So I don't think any system was designed to fail unless you have been part of a huge conspiracy. So basically, most of our health systems, unfortunately, are colonial initiated. We have been part of some form of foreign country rule at some point in our histories. So that is the main thing, and those are uh, in that has a good sense and a bad sense. So some things that we have simply failed to improvise on what has been handed down to us. So we have kept them as colonial legacies, and we have somewhere decided that this is all that we need. We have not applied our mind to improve ourselves. Maybe we have had fund issues. We were not in a state of development. And then we can't say or erase our history completely. We are what we are. And we can only say and assess where we are today and go forward from what we know. So I think it's such forums provide all of us to learn from each other. That is where the true beauty of this network that Dr. Satpathy has built comes in. So now you know what is going on in India, whereas what is going on in UK, US, and you can build it up. Nothing is rocket science, and the best human minds are the same everywhere. You just need a a curious mind, an unshakable spirit, and an unwavering effort to put work into things.
Definitely. Agreed. Dr. Rajalakshmi M is asking, sir, as you have discussed the role of environmental surveillance, such as wastewater surveillance at travel hubs, I'm interested to know if any similar strategies have been implemented in rural settings, particularly in South India. If so, could you elaborate on their scope and effectiveness?
Yes, if you look at in South India, there is an organization based in Bangalore. It is headed by Varsha Sridhar. So they are part of a Rockefeller consortium and they do wastewater surveillance in cities. There is also a similar cluster in Pune, which is not exactly South India. So they are conducting surveillance for AMR signatures in wastewater surveillance, especially in cities. You can read about them online. They're a pretty dynamic group and they have set up surveillance. ICMR is also doing surveillance with this, that is in Bangalore, based in Tata Institute of Genomic Studies for Societies. So they are also setting up wastewater surveillance in different Indian cities.
Okay, the last question to you. We'll compile all other questions later and we'll be sending to you, Dr. Anu. And whenever you're free, you can
Yes,
respond
sir.
and we can
Yeah.
send it to all the participants. So Ahmed Nafiu Abdullahi is asking, my name is Ahmed Abdullahi from Nigeria. Is it right to give some form of gifts or incentive to get more information from the locals during an epidemic regarding research ethics?
Yes, I believe that is a public health emergency. Yeah, it has its ethical questions, but then you need information fast. You need information, reliable information, and information comes at a cost. So whether you give money or in kind, or you give some vaccine in, you know, whatever you give to the particular community, if you need vital information, it comes at a vital cost.
Okay, so with this question and answer round, so apologies, my internet failed few times and the electricity went out. So I had to drop out for a few minutes. So apologies to everyone for that. However, we did the session very well. Dr. Anoop has dropped his email ID in the chat, so all of you can note it down. Whoever wants to contact and communicate to him. And it's been a wonderful experience for all of us to host Dr. Anoop Velayudhan, senior scientist at ICMR, Indian Council of Medical Research in New Delhi, India. It's been a wonderful experience and talking to you as well as learning from you. I am sure the participants have learned so much. Today is the first session, Dr. Anoop Velayudhan. I would like to inform you when our Zoom session has been completely full throughout the session. Like it started
Okay.
with 400 plus, it by in just 5 minutes it got 500 plus, and then it remained throughout for the first 1 hour. After that, it got dropped a little bit. Now it has again reached about 460. So that shows the level of enthusiasm of participants, and many are attending it live on YouTube, as it is streaming live on
Okay.
YouTube as well.
Okay.
So yes, so we
Okay.
have 2,700 plus participants who have registered for the entire workshop series since it began 2 months ago, and since then, worldwide, many stalwarts have come from different top universities in the world. And tomorrow again we are holding big sessions, national sessions happening, national sessions of importance because tomorrow is joint panel sessions happening for Nepal and Bangladesh. So today, on the eve of that panel, you are presenting about infectious disease epidemiology, and it's been hugely attended by people. They are sending a lot of personal messages to me on WhatsApp right now, in addition to the love emojis and emojis they are sending right now. So I'm sure they have enjoyed greatly, they have learnt a great deal, and they have benefited widely. So this is the spirit with which we run these advanced studies training certifications. So our admin team would be in touch with you, Dr. Anoop, regarding your e-signature, because that will be put on the certificate, and so they'll be in touch with you in just few minutes time rather, because we are very fast as a team. We are a very small team, let me tell you. We are a very small team, but we are as effective as today the session is happening, tomorrow we send out the certificates to people. And still participants do message
Okay.
us saying like where is our certificate, because they are sent in batches and they are sent throughout the week. So because there are lots of participants who are attending these sessions, and obviously we can't send everything in one email, it's not possible. It means we are not heavily funded organization that we can send out to thousands of people in one email. But hopefully, God willing, it might happen in the future as well. We take immense pride that we are the only global consortium of global health which exists and is led by actors, leaders, and thinkers based in Global South. We take immense pride in that. We also take pride that we are not funded by any corporations or governments. Therefore, we are fully independent and autonomous, and therefore we also exercise a lot of autonomy and sovereignty in terms of our voices and representation of voices. And so therefore we are indebted and grateful to you, Dr. Velayudhan, to come on a Saturday evening and spending so much time with us, delivering such brilliant expertise and experience that you have gathered in past 20 years of your work experience with different top agencies in the world. And I look forward to hosting you on another occasion at the global stage of Global Consortium of Global Health. I hope you had a great experience, although it's a virtual stage, still dealing with our training participants who come from literally all over the world, 170, 80 countries, literally. So we are very happy and that we are able to do it for the past 10 weeks. It's been a painstaking experience. It's not been easy. It's been actually nerve-breaking at times, without any support, nothing, very small team, but still we have been able to carry it out. And our training participants are very, very energetic, very passionate people, as you could see from the kinds depth of questions that are coming from different parts. And they're very curious to learn, they're very curious to apply learning into their workplace also. And we look forward to remaining in touch and obviously get you on our board of Global Consortium, and we shall be doing things for the betterment of the humanity, and that's the goal with which we are working for the past 8 months since its inception. In addition, I would like to place it on record: the Global Consortium of Global Health Actors, Leaders and Thinkers, the Global Health Forum, the Global Brain and Mental Health Forum, and the World Health Forum, as well as the Bangladesh Institute of Innovative Health Research, which is one of our local delivery partners, in addition to many other NGOs, are grateful for your presence and all your sharing and exchange of learning and experience. So with this, I would request Faisal to do the rest of the dues and I'm happy that my
Thank you,
electricity came
sir.
back
It was
because
indeed
my
my
video is
pleasure
like
and privilege. Yeah. And I am actually grateful for your invitation and to be part of this community. I'm very, very grateful for all of you for the patient listening, for all of your questions. And I hope I was of some use. And I also congratulate you, sir, and your organization for this initiative. This is the need of the hour, and this is we really need to learn from each other and share our experiences and leverage the technologies, the knowledge, our experiences, and who knows, tomorrow we can actually work together on the field, on a global question or a regional forum. It's a small world,
definitely,
and it's coming shrinking together with technology every day. So my
definitely.
sincere thanks to all of you. Thank you.
Thank you.
Thank you, Dr. Anoop Velayudhan, sir, for such an exciting and complex topics to be said. But you have delivered a very comprehensive session to our participants that engaged all the participants throughout the session. So thank you very much for your such an wonderful session and giving us the time. So, to all our participants, your attention, questions, and commitment fuel this movement. Let us continue to advocate for research, policy, and care that places people at the heart of systems transformation. So, we look forward to our next national panel discussions tomorrow. Until then, stay curious, stay hopeful, and good night, everyone. Thank you, sir, once again.
Yes, thank you. Thank you, Dr. Anup. I will be in touch with you and the admin team will be in touch
Thank
with you.
you. Yeah.
Thank you. Have a wonderful night and we shall be in touch. Take care. Okay. So
Thank you.
participants, the attendance and feedback link has been shared in the chat. So please have a look and fill the attendance form carefully. Many of you have committed mistakes in the past week by not mentioning your email ID correctly. That's the reason why you are not receiving your certifications. So please Pay attention, fill your attendance form very carefully. Please fill your name and the email ID correctly. Okay, and you shall be receiving your certificate in 7 days. That is 5 working days plus 2 weekends, so 7 days. So please remain patient, and you will definitely receive your certification if you have filled your attendance form. And Dr. Anoop, so thank you again, and you can still see that 370 participants are still here after 3.5 hours gone. So they joined at 6:30 and it's been 9:30. So 3 hours gone, still 370 people. So that's the level of curiosity and enthusiasm of our participants. We are very indebted and grateful. Yes, definitely. So yeah, and I'll have a meeting with you soon. I'll be calling you.
Sure. Thank you.
Thank you.
Thank you.
Have a great day. Take care. Okay, so participants, please keep filling the form, and now we shall focus on getting the process done. We'll close very soon, so the meeting will be closed in a few minutes. So please fill your attendance form. The attendance form has been shared in the chat. Okay, please be careful while filling the feedback form. Do not commit mistakes, and please fill your feedback form using the right email ID. The email ID that you use for your registration. Do not use several other different email IDs. Only one email ID and correct email ID. No mistakes. If you have committed mistakes, you will not get your certificate because it's automated. I cannot help, nobody can help. Okay. So if you enjoyed today's session, we are opening the chats. If you would like to share any feedback, you're free to share your feedback in the chat. Okay. In case you would like to share your views, opinions, anything, and feel it, put it in the chat. The attendance form has been put in the chat for the past 15 minutes. Now you can start filling it. Okay, thank you. Thank you, Ashley Dubey. Okay, wonderful to have you all. So stay tuned because tomorrow evening we'll have 2 big panels happening, national panels, joint panels, where lots of big people, stalwarts in true sense, the top of the health systems coming tomorrow for the countries Bangladesh and Nepal. Okay, so we will hear from the very best of the health systems top experts tomorrow from Bangladesh and Nepal. So stay tuned because tomorrow is going to be big. Thank you. I hope you had a good time. There is no age limit for filling the attendance form. You can fill it up. Anyone can fill it up. Affiliation, your institution, to fill that up. It's a international work subsidies. If you are not GSEP, then definitely international work subsidies. Yes. GSEP is an elite group of trainees that are getting trained in research skills with us for the past 3 months. Okay, so thank you. I hope you had a good time listening to this excellent, insightful talk, and keep learning, remain agile, okay, and keep participating and engaging in the learning and exchange of delivery of these important, valuable experiences. You don't need any cluster or group number for the international workshop series. You just say not applicable, NA, okay. For the GSEP, you must mention your cluster and group number. The GSEP participants don't need guidance. They have been doing for the past 10 weeks. For the workshop participants, International Workshop Series, IWS, please do fill NA for the cluster and group number. Okay. Thank you, Caroline. Thank you. Thank you, Vishwa. Thank you, Ahmed Jibril Baba. Thank you, Fatah Salahuddin. Thank you, Ali Hassan Elmi. Thank you, Eugene. Thank you, Oshia Manangajira. Okay. Thank you, Lucy Mahulu. And thank you, Jahanara Begum. Thank you, Rosa Ravieres. Thank you, everyone. Thank you, Mutari Abdul Shalami. And okay, good to know that time was well spent, Dr. Stella. Thank you, Kavita Chandra. Thank you, Bashma. Thank you, Shamima. Thank you, Bhai Ahmedu. Thank you, Ashan Balde. Thank you, Sadab. Yes, the presentation, the papers, presentation, the whole session has been recorded and streamed live on YouTube, which has been watched by hundreds of people already. So that will be recorded and it will be kept on the official channel of Global Consortium of Global Health. And that will be later shared on all other YouTube channels of our other partners as well. Okay, so therefore they are available. Uh, I don't know about that, Ali Nabil. If you have filled your feedback form correctly, then you will definitely get your certificate. That is not in my control because it is being taken care of a team. So that is not under my jurisdiction, honestly. So if you have filled the feedback form, definitely the admin team will be taking care of it. Thank you, Shaida. Last week's feedback last week's certificate of participation has been already sent out. So if you haven't received it yet, there must be some mistake in your feedback form fill up. You must have written your email ID incorrectly or something. Otherwise, we have sent it to everyone later. It's been already sent out. Thank you, Patai. Thank you, Ali Hassan. Thank you, Eugene. Thank you, Sadia Akhtar. You have to write free workshop, Sadia Akhtar, not the GSP. GSP is a training certificate, not for you. Thank you, everyone. Okay, thank you, Chandan. Thank you,